But we're not, you don't need to start recording yet.
It's recording now. So do I pause it? Yeah.
Okay. Okay, I think we're going to go ahead and start. We're going to talk about, this is kind of a little overview. Linda talked last week, right? About dysrhythmias and arrhythmias. So I'm just going to talk a little bit more about them. Not, she talked specifically about the different rhythms and went through, and Dr. Bucapatnam is going to talk next Thursday, specifically on atrial fibrillation. So if you have that or interested in that, make sure to attend that lecture. So anybody here or at home have a funny rhythm? What kind of problem do you have with your heart rhythm? You don't know. Oh, you were looking to see. Well, if you find it, let me know what it is if you want to. Anybody else have any or had in the past any heart rhythm problems?
I've got one. And I have a pacemaker to keep it.
What kind of problem did you have?
It's, I throw extra beats among other things. And I now get a beat back every now and then.
Okay, so you've got an automatic internal defibrillator.
I got one
Yeah.
for you.
Yes?
Specific heart block.
Oh, non-specific. Okay.
But it's hard to research something like that because it comes and goes on my 1280 EKG.
Oh,
It's kind of like every time I have an EKG, it might be there or it might not.
do you have any symptoms?
Not heart block. Did I say that?
Yes.
Bundle branch block.
Oh, bundle branch. Okay. All right.
My brain is out. Non-specific bundle branch, right bundle branch block.
Uh-huh. Okay.
Good Lord.
Yeah.
I'm making this stuff up as I go. No, it's non-specific right bundle branch.
So they don't really know what causes it.
No,
Yeah,
no,
That's the way with a lot of those. Yeah. Okay, so what is an arrhythmia? It's just a condition that in which you have irregular heartbeats or you have an abnormal rhythm of some sort. And the way that they categorize it is either by the site of where the problem is, or by the rate of the heart rhythm, or by where the conduction problem is. So you'll hear all different names of different rhythms called, but they're all based on kind of one of these three things. So you can see the way that the normal heart rhythm works is, I'm going to stand up here, is the SA node, which is right up there, that's automatic. So the SA node is an automatic part of the heart. It sends out, if you're not having any kind of heart problem, it sends out a electrical impulse down through the atria, through the top part of the heart to the AV node. And then from there, the AV node sends the electrical conduction message out to the ventricle. So there's first the top part of the heart beats and then the bottom part of the heart beats. So SA node, AV node, and then out to the bundle branches, which is where some of you said you've had problems, and the Purkinje fibers, which make the heart beat. So that's the normal thing that happens. But so if you have an arrhythmia, you can have a problem in any of these sites, in the SA node, the AV node, in the ventricles and the atria. You can have and if you have a problem in any of those areas, then you can have a problem with the rate. It can either be too fast, too slow, or it can be irregular. And that's because of and it can be because of the conduction system, which includes the bundle branches or the Purkinje fibers. So that's kind of shows you a good overview of there could be problems in really a lot of different places, and the problems can be different in that they can be slow, fast, irregular. Okay. All right. So that's kind of how it's categorized. So, you know, you hear if your doctor says you have an arrhythmia, it sounds scary, but you know, how serious is a heart arrhythmia, right? We get scared when we feel funny beats, or if on the EKG, we see that it's not quite normal, some are harmless and don't require treatment. So like I had a Holter monitor and I have a lot of early beats in the atria. So the atria sometimes gets excited and there's early beats there. And then I have some early beats in the ventricles sometimes. But they're just these random beats that I don't have long runs of them. So they're considered to be harmless. And I also can feel them. Some people can feel their funny beats and some people can't feel them. It doesn't, if you can feel them or not feel them, that doesn't mean that they're worse or better. It's just, we're all different and our ability to perceive things is different. So you can have a heart arrhythmia and it can be completely harmless and you may have had it all your life. So that's number one. Number two, you may have a heart arrhythmia which causes symptoms such as dizziness, chest pain, shortness of breath. So that's something that needs to be looked at because it's interfering. It can interfere with your ability to drive, to do work around the house, to socialize. So of course, you know, for those kinds of things, you want to let your doctor know and kind of try to get to the bottom of it. And some of those, you know, they may give you, they'll of course look for the underlying cause, but they may give you medicine that helps to just kind of keep it under good control. Some arrhythmias are very serious and could put you at risk for your heart actually going into a really fast rhythm and stopping. So those are usually the ventricular, the arrhythmias that start in the ventricles, the bottom part of the heart, ventricular tachycardia, ventricular fibrillation. And for those, there will be a treatment for that. So that's why sometimes, you know, you have an arrhythmia and nobody seems to really care. It's probably because it's not a serious one. So we all are different. The type of arrhythmia that you have can determine what kind of symptoms you have. And also just you as a person with your own symptoms and way of having an arrhythmia. We all experience these things differently. So it's going to be different for all of us. But these are some typical symptoms of arrhythmias. Palpitations, you may feel fluttering in your chest and your throat, right? Some people don't feel any of that ever. Even with really serious arrhythmias, they just don't feel it. And Linda, we've had patients that are in VTAC, which is a serious arrhythmia, and the ventricles are just pumping along really fast, and it's a dangerous arrhythmia, and they don't feel it, and they feel fine, actually. The reason they feel fine with VTAC is they're fortunate that it's not going very fast. If you're in a fast rhythm and it's VTAC, then you're going to be in trouble. So feeling dizzy or lightheaded, fainting, shortness of breath, chest discomfort, it could be chest pain, chest pressure, chest fluttering, also in the jaw or the throat, weakness or fatigue. I mean, especially with atrial fibrillation, sometimes the only symptom that you may experience is that you just feel like you can't do the stuff you used to be able to do anymore. You're not able to do grocery shopping, vacuum, those kinds of things, because you just feel tired and wrung out. And then having, sometimes with certain arrhythmias, you may have sweating or what's called diaphoresis. So anybody have any with their arrhythmia that they had? Did you have any symptoms prior to? Yes.
Yeah, I could feel my heart beating.
In your chest?
Yeah.
Like a palpitations or fluttering. Yeah.
It was funny under big time stress.
It got worse.
When I was young, I would pass out once in a while.
Oh.
Only really don't know what it was.
And did you feel the in your chest before you passed out?
It start drop into the low throat.
Uh-huh. Oh, so you had it for years before you knew what it was.
Oh, yeah, I
Wow.
fell off the bicycle.
Oh, man.
And, what is this? And then I was here and we ran into the same thing. And we got to the root cause.
So that was the atrial fibrillation, correct? Right. Okay. Anybody else? So that's a perfect example. You could have arrhythmias and then you don't feel them. So we're all a little bit different. But if you have any of these things, it's good. It could be a sign of an arrhythmia of some sort. So it's good to get checked out. So arrhythmias typically have a cause. Sometimes we don't know the cause, like the the bundle branch blocks. We don't know the causes of those. But these are some of the causes of heart arrhythmia. So if you're diagnosed, or if they see some sort of arrhythmia on an EKG, or when you're here, we feel your pulse, we feel an arrhythmia, something that's not normal sinus rhythm. The first goal is to try to get to the bottom of the underlying cause. So having blockages in the arteries that go to your heart is a common cause for a heart arrhythmia. So if your heart muscle isn't getting enough blood and oxygen because there's a blockage in those arteries, then of course the muscle is not going to be able to contract well. The fibers that are going through there can't work the way that they should because there's just not blood and oxygen going through there. So that can cause an arrhythmia. Electrolyte imbalances such as a low potassium, magnesium, or a high potassium, a high magnesium, those things can cause imbalances. That's one of the first things they might check depending on the type of arrhythmia you're having. Structural changes of the heart. What do I mean by that? If you have a heart attack, it could cause scar tissue in one area of the heart, which is a structural change. What's another structural change that you could have in your heart?
Viruses like
You could get like a pericarditis, or yes,
also thickening of the heart.
thickening of the heart muscle. Remember the lecture? Yeah, I'm sure you all remember the lecture that I gave on heart failure. And I showed that you can get an enlargement of the heart muscle where the muscle thins out and the wall gets thinner, or you can get a thickening of the heart muscle where the heart muscle gets thicker. So those are two very common structural changes that can occur. What happens when you have atrial fibrillation in terms of structural changes of the heart? Anybody know? Atrial fibrillation occurs in the atria, so the top part of the heart, and the top part of the heart's beating kind of irregularly like this. It's going faster, it's a little erratic, there's little electrical conduction going on to places it shouldn't be going. So eventually what happens if you don't take medicine to slow it down or stop it or have some sort of procedure, have a pacemaker, the heart, the top part of the heart's working so hard, overworking, that it starts to enlarge. So you can have an enlargement there. So that's a structural change. And the more structural changes you have, then the more arrhythmias that you can have. So it's just kind of perpetuates itself.
About that story a year or so ago, I think it was a football player got, blasted in the chest.
Yeah, on the Buffalo Bills.
Oh, and then he needed CPR, right? Yeah. Yeah, it probably got blasted so hard that it just interfered, number one. And he may have had contusion there, some blood, right? Blood that went there and surrounded the heart. It's kind of like what you were talking about with the virus, where blood gets in the sac and then the heart can't pump well. And you certainly could get arrhythmias from that. He must have had VTAC or something when that happened, and then VFib. So scarrings, what causes scarring? The main thing that causes scarring is having a heart attack, but other things can cause scarring. It's very common to have arrhythmias after surgery, specifically after heart surgery, because of the healing process that's going on with the heart. High blood pressure, just all on its own, cause heart arrhythmias because your heart's having to work harder to pump out against the high pressure. Diabetes, all on its own, can cause you to be at higher risk for having arrhythmias. Illicit drug use, more and more common now, methamphetamine, cocaine. Those things cause fast heart rates, but also they can cause, meth and cocaine can cause structural changes in the heart, can cause the heart to enlarge or thicken, and that can cause you to have heart arrhythmias. Excessive caffeine, I looked this up just to see what excessive meant. And because I personally wanted to know. Now I've looked this up before, years ago when Dr. Capagoda was around, we researched it and he looked at it, and it seemed to be just in general caffeine, it was considered unhealthy for the heart if you had 10 or more cups a day of caffeine, so pretty high. But they weren't talking, back then, they weren't talking about espressos. They're talking about that kind of diluted kind of coffee that would come out of a percolator, and a smaller cups. So those were the 10 cups. It's almost like drinking colored water back then. It wasn't like the coffee we have now. So the research now is showing 5 regular cups of regularly caffeinated coffee, which is about, I think it was said about 100 milligrams of caffeine. So having 5 of those or more is considered excessive caffeine. And it's considered at that rate, you may start to see some increase in arrhythmias. But they've really studied this. And below that, I mean, the NIH, I looked at the NIH, I looked everywhere. They're not really saying that caffeine is associated at lower levels. Although I have had patients that are 100% sure that when they have caffeine, it, causes their arrhythmia to get worse. And kids, young kids, they think they're not drinking coffee, but they're drinking these energy drinks, and that's like drinking 10 cups of coffee. And there's, when I was looking this stuff up, there are a lot of studies on younger people that come to the ER with feeling short of breath and nauseated because they've been drinking these energy drinks, and it is causing a really fast rhythm because of all the epinephrine that they've got going. So problems with your thyroid. Of course, stress can cause you to have a faster rhythm. And one of the things I don't have on here also is, what did you guys all do today already that can cause your heart to go fast? Exercise. That's not considered to be an arrhythmia, but it is called sinus tachycardia, which means you're still in sinus rhythm, but your heart is tachycardia going fast. And that's a normal response to exercise. Smoking can cause arrhythmias, and supplements such as herbs. And I specifically looked up to see what kind of herbs and supplements. And the ones that are really, they've studied pretty carefully and are associated with increase in arrhythmias are something called bitter orange, things that have ephedra in, which ephedra kind of been banned, but I think they still find it in some things. Something called mate, and then green tea in large amounts. And I couldn't find the specific milligrams for green tea that causes it. But all the green tea specifically, it's going to be, having a cup or 2 of green tea a day is not it. It's these higher levels where they put concentrated amounts of green tea into these herbal supplements. And it's not like drinking a cup of green tea. It's concentrated green tea.
Article in today's New York Times that they think some of these fish oil supplements that cause.
Right, and fish oil. Yes, I saw that too. I think it's the high amounts. He's concentrated.
Well, yeah, they're selling
Right.
5,000.
Right, that's right. That's right. And we think because it's fish oil, it's fine, or because it's green tea, it's fine. So, but they're putting them in these concentrated amounts and they haven't really been studied. So high doses. And then some medications that you may be on can cause arrhythmias. So, if you're put on a new medication and then you notice that you're, short of breath or you feel palpitations, of course, call your doctor and get that checked out, because sometimes they can put you on a different medication that will do the same thing, but won't cause arrhythmias for you.
To me, part of the new blood pressure medication.
Uh-huh.
It's riding, it started having palpitations.
Uh-huh.
So I pulled over the side of the road. It lasted for about 2 minutes.
Yeah.
So after work, and I checked the medication, and sure said on medication, we had these episodes.
Yeah. Yeah. So that's a good example. So be careful when you start a new medicine if you notice you're having palpitations or symptoms. So this is we've kind of talked about this a little bit already, but what puts you at higher risk for an arrhythmia? So of course, the things that we talked about, using tobacco products, including vaping. Vaping, nicotine is just as bad as smoking. Alcohol can be associated in some people with arrhythmias. Caffeine, moderate amount is okay, as we discussed. Taking over-the-counter stimulants, herbal meds, or cold medication too, things that have pseudoephedrine in them. Having high blood pressure, just also being overweight has an association with higher arrhythmia risk. High blood sugar, sleep apnea associated with development of atrial fibrillation. Having a previous heart attack or heart surgery, likely because of scar tissue and maybe some inflammation in there. And as age, we're at higher risk for arrhythmias. 12.6% of people greater than 65 years of age have an arrhythmia. And that's compared to the general population. The risk is about, I think it was 1.5 to 5%, depending on your age and ethnicity. And So much higher as we age, having a family history, having a congenital heart defect, so being born with some sort of valve problem or problem in the heart muscle, and thyroid disease. So they categorize arrhythmias in different ways, and one of them is based on the location. So the two locations are either in the top part of the heart, those are called supraventricular arrhythmias. So see where the line is there? So anything above that line, that's the atria. Those are the two atria, left atria, right atria. That's called supraventricular. And then, or they're ventricular, which is below that line. So you can see up here, there's all the different arrhythmias you can have that are considered supraventricular or up and above the ventricles. Those are all the ones, you know, atrial fibrillation, atrial flutter. See all the atrias they're talking about, ectopic focus, where there's a little area of the heart that's just firing off for some reason. You can also have problems in the AV node that I talked about that's, you know, goes from the SA node to the AV node. So you can have problems right in that AV node that causes the normal conduction to be disrupted. And then all the ventricular arrhythmias, ventricular tachycardia, ventricular fibrillation. So that's one way. So you might hear your doctor talking about it, or friends talking about, that's one way that they can categorize an arrhythmia is by the location. Other ways that they categorize arrhythmias is whether it's slow or fast. So is it a bradyarrhythmia, which means slow rhythm, or is it a tachyarrhythmia, which means fast rhythm? So you can see all the different things. I'm not going to go through all of each of these, but there's, sorry about that. There's sinus bradycardia, there's AV conduction blocks. And then on the tachycardia side, the atria, there's can be a little focus in the atria that's sending off these rapid electrical impulses. Atrial fibrillation can be a fast rhythm in the top part of the heart. And then there's ventricular, really fast rhythms in the ventricles. So location, fast or slow. That's how they're going to categorize. So a bradyarrhythmia is an arrhythmia problem with the electrical conduction system. Certain medications can cause this to happen. What's a common medication that could cause your heart to slow down that a lot of people are on? Beta blockers. Yes, excellent. Good job. Yes. Any other ones that people can think of? Digoxin, that's an old one, a common one. Pretty easy to get digoxin toxicity, which can cause a very slow heart rate. Not so many people on digoxin anymore, but it used to be a big problem. So certain medications, also having scarring in some area from a heart attack, past heart attack, toxins, can be things like chemotherapy, or it can be toxins such as cocaine or methamphetamine that damage the heart, cause structural changes to the heart.
So is chemo one of those things that for the heart, that can be treated for someplace else in the body? With the chemo.
Yes, that's exactly right. Yeah, it's not like you don't get, chemo doesn't necessarily cause problems just because if you're having a heart chemotherapy for the heart. No, if you're having treated for, you know, breast cancer or some other kind of cancer and you get chemotherapy medicine via IV, it just affects the heart. So for some people now, specifically, I think it's for breast cancer, they're women that are getting breast cancer, some of them, they will put you on a beta blocker prophylactically because they've found that beta blockers help prevent the damage to the heart. So some women now are being put on beta blockers just when they're getting high doses of chemotherapy.
So understanding for women after they've had chemo,
the risk of having heart damage, so you can get heart enlargement, you can have heart attacks. Yes, yep. So, bradycardia can be caused from some problem with the SA node, that's where the automatic beat starts. Something can happen. There could be scar tissue there. There could be an expansion of the atrium, which is kind of pulling on the SA node. There could be a problem with the SA node. Or there could be a block somewhere along the way where the conduction is just being blocked because the heart's gotten enlarged, or there's scar tissue, or there's some problem. We get problems with our nerves all the time, and our feet, our legs, same thing can happen in your heart. So these are some of the supraventricular arrhythmias. So those that are in the atria above the ventricles. The most common one, especially as we get older, is atrial fibrillation. And Dr. Buchmann will talk extensively about that next week. Oh, this week. Oh, tomorrow. I mean, Thursday. And these are the ventricular arrhythmias. Anybody have PVCs or have had, yeah, PVCs. So you have a pacemaker in that also has a defibrillator on it. And that will detect, it's a cool thing because it will detect if John's heart starts going fast, and then it will give him a little shock to stop that dangerous arrhythmia. Have you ever had it shock you?
Yes and no. It has repaced me, but it has not shocked. It's doing its little.
That's what it's supposed to do.
Yeah, the
So-
first thing those they're either called AICDs or ICDs will do is detect the rhythm and try to send out its own conduction to try to overpower kind of that funny conduction that's going in the heart to pace the heart back to a normal rhythm. And if that doesn't work, then it will deliver a shock.
The situation with PVC, from twice in recovery when the nurse said, "You're only PVCs." They go on the dry side and
Yeah,
twice. Doesn't always be good.
right.
So, yeah, I'm ready.
Yeah. Yeah, situational, and from having anxiety or stress, family stress is the biggest stress that we all have. They've done studies on it. That's what causes us the most stress, is family issues. And yes, and then you've got more of the sympathetic nervous system being stimulated, so you're more likely to have PVCs.
Your electrolytes are off, like say you're really depressed with magnesium.
Yeah.
That cause arrhythmia.
Yes. One of the most common causes of arrhythmias, yeah.
I bicycle, but don't much their fluids have arrhythmia issue.
Yeah, sometimes on a, well, same with swimming too. If you're on a bike, because I ride the bike, and I don't get that thirsty, really. I'm just one of those people that doesn't get thirsty, but you don't realize it how you're sweating because the wind is just blowing it off you. You're constantly cooling by the wind, so you don't realize that you're sweating. And in the pool, the same thing. You don't know that you're sweating in the pool. So I don't know. Is it more common in bicyclists to have arrhythmias?
Acronym in the breath.
Really?
It's more common than women.
Interesting.
I think it's higher than the 12%. They put it that.
Wow. Well, those guys are going fast, yeah.
Especially around the Tour de.
Yeah. Yeah, interesting. Well, I'll have to look that up. That's interesting. Okay, so say that you feel palpitations in your chest, or you had some sort of procedure and they do an EKG and they see some sort of funny rhythm, or you come to here for exercise, and when we're taking your blood pressure, we can hear that your pulse is really slow, it's in the 40s, or it's irregular. So that's the very first step, is that you notice that there's something different. So then you go to your doctor and they will evaluate it. These are all the different ways that they could evaluate the arrhythmia depending on what they think is going on. So the oldest way one of the oldest ways is wearing what's called an ambulatory EKG, which is also called a Holter monitor. Used to be this big thing. They're a little smaller now. Is that a Holter monitor?
No.
That used to be like
It
that.
used to be
That's the size. Yeah, that's exactly the size. Big, and you had electrodes. Oh, I think there were 8 electrodes all over you. They'd come off because they get pulled off by this heavy Holter monitor. Anyway, they're much smaller now. They also have something called an event recorder where you can press the button. It's also external. It's smaller. It's just a little thing, but you press the button if you feel shortness of breath or feel palpitations in your chest, and it will record what's going on with your heart rhythm 2 minutes before you press the button, sometimes longer now. They've got longer ones, and then afterward. And then you're,
Or 2 minutes before you push the button.
yes, well, you push the button, but it has already recorded, but it kept that information. They'll save it, yeah. And then there's implantable loop recorders now, a small device. And this is a picture of it. It's just a little thing that's about the size of your finger. And they implant it right next to your heart, and it will record every beat that you have and send that message to your doctor, I think, I don't know, every 24, 48 hours or something. And they can see what's going on. So that's good for people who don't have symptoms, or if they do have symptoms, but it's hard for them to catch it. But they know something's going on, they might do something like that. Sometimes they'll do a stress test where you exercise treadmill test, walking on the treadmill, riding the bike, because that will get your heart rate up. It stresses your heart. Sometimes funny rhythms will come out on a stress test that you don't see normally if you're just doing lower level exercise or sitting. Imaging tests like echocardiograms to look at whether you're having enlargement in your atria or enlargement in your ventricles. They may do a cardiac catheterization if they suspect that you're having some sort of underlying cardiac blockage or some sort of structural problem with your heart. And sometimes they suspect there's a problem with the nervous system, and they'll do what's called a tilt table test to see how your heart rate and blood pressure respond to different positions of your body. So what do we do about arrhythmias? All sorts of different things. Medication management. So there's all sorts of medications depending on the type of arrhythmia that you're having. My watch thinks I'm talking to it. So if you're having arrhythmias that are irregular, very fast, they'll put you on an antiarrhythmic. If you're having rhythms that are too slow, they'll put you on something that can speed up your rhythm. Too fast, they'll put you on medications to slow down your rhythm. So and we'll talk about each of these a little bit. So the focus for medication management is to return your heart rhythm to a normal rhythm, back to normal sinus rhythm or normal conduction. So the main goal is to prevent dangerous arrhythmias such as VTAC, VFib, and any kind of antiarrhythmic that they put you on will be focused on that. They may put you on something that will help with the rate. The other treatment for arrhythmias is a cardioversion, and that's where they actually give you a little medicine so you're not fully awake for it. You're relaxed. You really don't hopefully know what's going on. Very short acting anesthesia, and they'll shock the rhythm right during the tall wave of the rhythm, and that will shock you out of some rhythms. The rhythms that they use this for sometimes is supraventricular tachycardia. That's where your heart's just going very fast and they're not able to get you out of that in any other way. Used also for atrial fibrillation or flutter and stable ventricular tachycardia. When I turn my phone off, sorry. You may be given a blood thinner for at least 3 to 4 weeks before and after cardioversion to prevent a stroke, depending on the type of rhythm that you're having. Another treatment is a pacemaker, which some of you guys have been talking about already. Pacemaker is a small device, tiny wires, although they have pacemakers now that don't have any wires connected to your heart. It produces an electrical impulse of its own. So sometimes the pacemaker's there, we've already talked about, to try to pace you out of a fast rhythm. It helps your heart beat at regular intervals. There's different types of pacemakers. There's pacemakers that have a wire that just goes to the top, one single wire that either goes to the right atria or the right ventricle. There's dual chamber pacemakers, which go to the atria and the ventricle. And then there's a biventricular pacemaker, which has a wire that goes to the atria. And then there's two wires that go to each ventricle. Sometimes they will do, this biventricular pacemaker is common in people that are having problems with their cardiac output, or if you have damage to your heart, you're not able to, the ventricles aren't able to pump out enough blood. So if you get both ventricles beating synchronously with having two leads there, then you have better cardiac output. So instead of the ventricles kind of going like this, not very good cardiac output, you've got this good together, teamwork. So that's why they put in a biventricular pacemaker. And we've already talked about the implantable cardioverter defibrillator, the ICD. Small battery-powered device placed in the chest. It's attached to leads that sit in the heart. It continually, it's like having like a guardian angel watching you, watches your heart all the time, detects if you're having a dangerous rhythm, first tries to pace you out of it by sending little electrical impulses, and that doesn't work, then it will give you a shock to, like, it's almost like doing a cardioversion, shocks your heart to interrupt that dangerous rhythm and get you back into your normal sinus rhythm. There are also maneuvers for specifically for supraventricular tachycardia, and these are called vagal maneuvers, which stimulate the parasympathetic nervous system, which is the part of the nervous system that can slow down the heart rate. So it's things like if you're somebody that has SVT, we had when my kids were swimming, there was one kid on the team. He would get nervous and he'd have all this epinephrine surging, and he'd go into an SVT right before he was going to swim, right? So he learned to do these vagal maneuvers, which either bearing down, you bear down by trying to blow on something like a pen or a little straw, it causes you to bear down where you're just tightening everything. That stimulates the parasympathetic nervous system. Coughing repeatedly, that causes a bearing down feeling. Holding your breath, and cold water on your face. Also, doctors or nurses sometimes will do carotid massage, which stimulates the vagal nerve, which will slow your heart rate down. These are not to be done if you think you're having a heart attack or a stroke, because all those vagal maneuvers, right, cause your blood pressure to go up, which is not what you want to have happen if you're having a stroke. So these are specifically if you know that you have SVT and you know that these vagal maneuvers have helped you in the past are going to be helpful. So lifestyle changes for treatment of arrhythmias. So, managing your blood pressure. If you're somebody that has more of these arrhythmias, any of them, either atrial or ventricular, both of those can be sometimes better managed if your blood pressure is under good control. Managing your blood sugar levels, avoiding smoking, avoiding vaping, avoiding stimulant medications such as over-the-counter cold medicines, some of the herbs and supplements I've been talking about. You guys were great at talking about how they're putting these higher amounts of what we consider to be normal things like green tea and such in these over-the-counter supplements.
Where's the money to have cocaine?
Yeah, right. I don't know how much it costs, but I'm sure it's expensive. Yeah, just putting all that money out would cause me to have PVCs. God. Let alone trying to find somebody on the street to sell it to me. That would also cause me stress. How do you do that? Avoiding illicit drugs, achieving a healthy weight. Always achieving a healthy weight must be in every lecture that we give in here, right? The hardest thing to do, but there it is. Know how to take your heart rate. So normal is 60 to 100 beats a minute. learning how to kind of monitor that yourself so you know if you're having an arrhythmia. If, you know, you can always come to any of us and we can teach you how to take your heart rate. Sometimes it's easier to feel up here in your neck. Sometimes you feel it really well. People have really strong in their pulse, especially if you get your wrist in the right position. Sometimes it's all just a matter of getting that wrist in the right position. So if you need help with that, come to any of us, we'll help you with that. Also, there's smart watches now that you can set to tell you if you're having atrial fibrillation or to monitor your pulse, and you can check that every day and see what your heart rate's been during the day. Call your provider if you're having any of the symptoms, if you're having dizziness, lightheadedness, palpitations. Those are not normal things. So call your provider and get checked out. Take your medications that you are prescribed as prescribed, and avoid activities that you know trigger your arrhythmias. Having arrhythmias can be stressful, but like I said earlier, get information about them. Talk with your healthcare team about your arrhythmia. You know, you may have gone to see your doctor and they may have said, oh, you know, I looked at your EKG and it looks like, you know, you've got some premature atrial beats. And then he moves right on to something else. And then you leave the office and you're like, oh my God, I've got premature atrial beats. What is that? And then you look it up and you got all these people talking about how they passed out from having atrial arrhythmias. And then before you know it, you've got sympathetic nervous system going and you really do have some problem there. So you want to get information. If you hear something like that from a healthcare provider, get more information about it. Is this dangerous for me? What is this? What does it mean? You know, that sort of thing. Because you don't want to be running around thinking that you have a big problem when you don't. Because that can cause fear, anxiety, depression, stress, which you may not even be need to having because what you have is not dangerous. Talking to a professional counselor, once you know what kind of arrhythmia that you have and get information about it, talking to somebody about your fears and worries can also help. And learning ways to manage your fears and your anxiety. All sorts of apps that you can put on your phone now that are good reminders to take deep breaths, to meditate, to stop ruminating, to think good thoughts, those kinds of things. You may need medicines or other treatments that can improve your quality of life or improve your arrhythmia. There's support groups, especially for those with an ICD. There's support groups available for those individuals, and mindfulness activities such as meditation, relaxation, body scan, and different types of Tai Chi and those sorts of things can be helpful also. Any questions or comments? Okay. All right, if you think of anything later, always ask.
When does the doctor normally tell you you need a pacemaker? Is it just because when problems become chronic, or is it beforehand, ahead of time?
Two reasons, I think. I think it'd fall into two. The question was, when does your doctor tell you need a pacemaker? I think if they're seeing something that they know is going to be very dangerous, like ventricular arrhythmias that are fast, they'll put in an ICD and a pacemaker, even if you're not having symptoms. The other reason that they'll put a pacemaker in is if you're having a rhythm that's causing symptoms that's interfering with your ability to drive, to do your life, to exercise. You don't want to be running around like that. So it means that your heart rate's going too slow or it's going too fast, and they'll put in a pacemaker to help with that.
Is there a numerical number that they look for that's over?
A normal rhythm is 60 to 100, but people are walking around with heart rates of 48 and you're not having any symptoms and you've got good cardiac output, it's not a dangerous arrhythmia, you're not having runs of VTAC, they're not going to put a pacemaker in. So I think I would say it's individualized. Yeah.
You used to see athletes in the hospital they had the heart rate somewhere between 45
Yeah,
Falling acid is a non-rate,
yes. Right, right.
so these nurses. Even if it looks at them on the house to make sure.
Yeah, and how's their blood pressure? They have a heart rate of 42, but their blood pressure is completely normal. Oh, well. You know, because they've got really good cardiac output, so they're able to make, because their heart is so efficient. Um, their heart rate doesn't have to be as high because they've gotten so efficient. Peripherally and centrally. Good, good to bring that up. That's true. All right, so yeah, anything else?
So the BMI number in Ford is 30, they want to get below 30.
Oh, gosh, I can't remember. I can't remember the numbers for there's obesity, there's morbid obesity. I can't remember the numbers.
Yeah,
I can look that up for you though.
Well, 25 BMI, 25 and over.
I think for men,
Obese.
I think I think for women, 25 is okay, 23 for men, but I'll have to look it up. I can't remember. I'll look it up.
It's just weird that that's the number. Well, it's supportive, like people who are skinny and healthy.
Right, people that have, yeah, it's supposed to be a little bit less accurate in men, and they say that because men have more muscle, you know, and so that can be, especially if you lift weights, you know, you can just be more dense. So the BMI is not as accurate. Also, some people just, as we all know, have bigger, denser bones, so that weigh more. So yeah, it's not always completely accurate, but a lot of studies done on BMI, and there is strong associations between certain BMI categories and illness. So there is that association, which you can't, it does exist and is true, but
So it's a target range for heart patients.
it's the same. The heart patient range for BMI is the same as it is for the general public. And you see heart disease goes up at a certain BMI, which is once you start getting into the obese category, then you start seeing increased heart problems. Well, you know, it's there in the literature.
And I had a 2 hour. Requirement. Now presenting a session. And very active. Very active. And her perspective, of course, was. We could. I think that was. Yes, as working in the field for the last 20 years, she takes a serious point of view about weight. From the other view, she tempers it with another point of view about what's really considered healthy.
Mhm,
And she was giving examples of different weights.
mhm.
Usually protein, it's usually
Yeah, yeah,
so it's not something that, happens to somebody who's like 200.
Yeah.
Not typically, unless there's someone with that.
Mhm.
Yeah, I guess I was trying to wrap my head around it because weight is a big issue. And it's also very stigmatized.
Yes,
So that 2 hour talk, we start to think about it. Cause I know a lot of individuals who are overweight, but their blood pressure, heart rate, and have heart issues, and yet they're overweight. They're still at risk perhaps, but you know, I often wonder how they continue to come up with numbers that's healthy and that's considered.
It's probably a whole discussion.
You know.
Yeah, I
it's-
think that would be a good lecture.
I.
Because I'd like to see the most recent literature. I do know that with this Ozempic and drugs that are coming out now, it's amazing because we're seeing all sorts of improvements, like in rheumatoid arthritis, with just 20 pounds of weight loss, you know? So there's all sorts of things that we don't know about fat cells and the inflammatory response that we have from it. I mean, I just think there's so much research going on now and things that we don't quite understand. But I will say for, years, the literature supported that, once you get in that obese category, there is an increased risk. And, we don't really know all the reasons why. And I think Ozempic is bringing all this kind of out into the open, that there's a lot going on that we need to learn.
You know, starting what companies are doing something, they're trying to limit it only to type 2 diabetes. So anybody else trying to get it for any other reason are insurance wise are getting shut down.
Oh,
One right after.
really?
And I don't
Just
know
with Ozempic or the other ones?
what it is.
Because there's all the other ones
It's,
too.
They've relabeled it Wegovy too. so-
Yeah, right. Yeah.
People who have the
It's
resources,
It's not Wegovy.
people who have the
So
resources.
she's one, and she's the specialist in immune stuff. There's
Would have been to be
oftentimes
stuck with
Davis and other
Did you talk about
hospitals
ablations at all,
refer to
Sharon?
Sutter Rose.
No.
For these kind of
Because
surgeries.
I think Radika's gonna talk about that. That's mainly for AFib. I mean, there's other ones, but.
I didn't talk about ablations. Linda's saying that I should. She's giving me that look. She's giving me that look back there.
Has anyone ever here had an ablation or been told you should have an ablation?
They all left.
They all left.
They all have.
Sometimes if they can, I had an ablation done for AFib, and for certain things like AFib is a really great one to treat with an ablation, because they can go in and do the study and they can actually find the little area that is being conducted, and then they just burn it, they just ablate it. So when the little electrical conduction tries to go down that nerve, it can't go down there anymore. So then it'll go down the correct path. Instead of the wrong path. So, and they can do that for other arrhythmias too, depending on what they are. But
Good afternoon, everyone. This is Vicky at home. And I had a maze procedure, if anybody knows what that is.
oh yeah, I mean,
maze.
yeah, do you want to say what it is?
No, you can tell them.
It's it's an older procedure that they have done for years, and it's where it's the same idea as an ablation. They just they go in and they just burn little areas in the atria, kind of all over, little spots, little tiny spots. And the idea is that the funny little electrical conduction system for the AFib is going to go through one of those, because it goes over and it'll get stopped because that area has kind of been burned. Yeah.
And
How many years ago did you have that?
About a year ago.
Oh, recent. I don't know how it's a good question for Dr. Bukapatnam. I don't know how they determine whether to do a maze procedure or an ablation.
I think they did it just because they had to do open heart anyway, and I was laying there, so they figured it was easier just to
Oh, okay.
make all the scars right then and there.
I see. And how have you been?
I haven't had any problems with that.
Good.
Nothing. Yeah.
Yeah.
It's been wonderful. I had two valves replaced and one repaired. All at the
Great.
same time.
Good.
So I've not had any complications from it at all.
That's wonderful.
And you were talking about drugs that slow your heart down. Amiodarone is another one of those, right?
Yes.
That can, yeah.
And
I was on that for a while.
an
They took me
is
off.
considered an antiarrhythmic.
Yeah.
Yes. Are you on that?
No, not anymore, thank good. No, it's too
Yeah.
hard for your kidneys and liver, so
Yes,
they,
it's
my doctor
very,
took me out.
amiodarone has a lot of side effects, so it's good if you can have a procedure done so that you don't have to take those medicines.
Really, other than Eliquis, the only thing I'm on is 12.5 milligrams of metropropyl.
Good. That's a good
So
one
I,
to be on.
yeah,
That's excellent.
that's all I'm on, and Lasix once a day.
Good.
So
You're
I'm doing
golden.
well.
You're doing
Yeah,
well.
yeah, grateful. And now working at the center there, I hope I get even better.
Yes, you will. It'll help.
Thank you, Sharon.
All right. Thank you,
Thank
everybody.
you.
I think it's a good idea for, we